hospital. So are there any two of you that want to come to the hospital tomorrow to do real, so I can let her know? I want to come in the morning. Because the only person who told me they didn't want to go was Courtney.
I didn't say I didn't want to go.
Well, now's your chance.
I gotta work tonight till midnight, so I'll.
She knows, the sub knows what time we get out, right? I only asked because my best friend's coming in town, so.
Because I'll see her on Thursday. So you just give her her paper, give her your paperwork, and she'll give you your stuff on Thursday.
What's her name?
Lysandra Washington.
Lysandra?
She'll find you, don't worry. All right. It should be easier though finding placements tomorrow since that other group won't be there. So I will give her a list and I'll email you guys out where you're going to be tomorrow. I feel like I'm going to die.
Me too.
So do I.
All right. So,
Am I coming?
You want to take a break and stay?
no, I need to finish while I'm still no break. We talked last week about the blood products, right? Or I can't remember what class I'm in anymore. But most of the things, when we talk about hematology, your disorders are going to come from either decreased or increased production or decreased or increased destruction of some type of cell type. And what you have to do is think about what cell type it is, and then you can figure out the problem that you have. Because pretty much everything in hematology is going to sound exactly the same when you read it, about how the patient presents, signs and symptoms that the patient has. You'll always see fatigue and weakness as part of everything you see in there. So think about the roles that each of the cell types do. RBCs play a role in acid-base balance, but primarily they're with oxygenation because they're the heme portion of the cell carries oxygen throughout the body. WBCs play a role in fighting infection and immunity. So patients who have problems with those disorders either have infections, can't fight off infections, or are susceptible to getting them. And then we have platelets, which play the role in clotting. So if a patient has too little, they're bleeding. Too many, they will actually develop clots and can have thrombic type of conditions. So most of the things that we have as far as hematology goes are acquired. In NP3, you should have got parts about the congenital ones. But most of the ones that kids have that are passed on through gene kind of things, you talk about in NP3. But here, most of the things we're going to talk about are related to patients having some type of acquired hematologic disorder. So with the ones we have for RBCs, we're going to talk about acquired anemias, hemorrhage, and blood product administration, which we talked about last week. But y'all, it goes back to those types of things. Then we're going to talk about thrombocytopenias. And thrombocytopenias can exist in various forms. All I want you to really think about is the patient has too little platelets, what kind of things you're going to see in the patient. Because there's an idiopathic form, which we don't know why it happens, and there's an autoimmune process. And if you look at the name, you figure out what's going on with the patient. Then we have our leukemias, and we're going to focus on the ones that happen more in adults. Although ALL does happen in adults, acute lymphocytic leukemia, it happens quite predominantly in children. So the ones that you're going to look at are AML, CML, and CLL. So the A, when you talk about leukemias, A is the acute piece. So that tells you that the onset of symptoms is quick and immature cells are associated with them. When you look at the chronic leukemias, those are things that have an insidious onset. Symptoms kind of mimic all different other types of things that your patient has, and mature cells are with them. Of the leukemias that patients can have, the myelogenous side, meaning acute myelogenous leukemia, and chronic myelogenous leukemia are the ones that have the poorest prognosis. So then we have our lymphomas, which are Hodgkin's. Hodgkin's was the first lymphoma that was named, and then we start seeing some things that were not that way, so then we got non-Hodgkin's lymphoma. But it's something that happens in the lymph system, so you primarily see lymphadenopathy with this as their presenting symptom, where you talk about seeing the patient. Out of these, if you had to have one, Hodgkin's is the better prognosis. Non-Hodgkin's lymphoma has a poorer prognosis. Neutropenia is the decrease in white blood cells, so the ability to be able to fight off infection is lost for the patient. When you see different types, and when you'll talk about if you have patients who have infections, you'll see certain cell types when you're looking at the WBC report, eosinophils, basophils, neutrophils. When you talk about neutropenia, they're really talking about the neutrophils primarily. But they also, those are things that happen when you talk about the white blood cell, breaking it down, tell you what the patient was exposed to, kind of thing. So if you have a person who has an allergy, they actually have eosinophils higher. So when you're talking about basophils and neutrophils, those are infectious processes that patients have. So we're going to talk about that, and they talk about it being relative or absolute. Absolute means you have none. Relative means they're very low. But the thing about it is when patients have neutropenia, it's all about safety, protecting them from infection of all types. And so most of the neutropenia that we talk about in this section has to do with because we give drugs to treat with leukemia and the cancer, so therefore the patient has leukemia. Then we also have multiple myeloma, which is primarily, I mean, even though you see this as, that we talk about in this course, multiple myeloma is really a chronic condition for the most part. Some patients present with a very aggressive form and end up with an acute cancer, almost like a leukemia. One of my instructors who works with me on Saturdays, his mom, actually, she was diagnosed and has been very sick. And usually most myeloma patient is kind of moseying along. We don't see a whole lot until later in life. So it just depends on what happens with the patient. They can end up doing a lot of different things, even though this is something that happens in bone itself, because what it does is causes like a Swiss cheese appearance to somebody's bone. So they end up destroying the matrix of the bone itself, pathologic fractures that you see with it. They produce a protein called Bence-Jones that they do when they see this in a patient. But most patients can have a course where they are pretty much stable for a very long time. It's rare that you see a person has an acute form that's that aggressive as far as their disease goes. It is something that happens, but it's kind of prolonged over time. Okay, so first thing we're going to talk about, and you know normally I would let you go after a test, but we got to catch up kind of thing. So if you guys will be caught up anyway, so I'm not really worried about us. It's my evening class that takes a little longer. Acquired anemias are those anemias that happen because of certain things. Now in MP2 we talked about them related to patients having nutritional deficiencies that cause them. So that was the B12, the folate, those types of things, iron that cause the anemias. Now when we talk in this class, we're mostly talking about related to, there's something that causes decreased RBC production either from chronic disease or it's because the patient has blood loss. So acute blood loss, of course, is going to be hemorrhage that you kind of see that goes along with that. So when you have patients who have anemia, one of the things that you want to see is the abnormal value that you want to see on your lab work is our retic count. Ooh, had to think about it. Reticulocytes are mature RBCs. So when you have a patient that has an acute blood loss, when the retic count is up, it's saying that bone marrow is being stimulated to make more cells. So you know that's totally abnormal with what type of disorder that was from your MP3 test. That kind of told you your patient was having a problem when their retic count was high. Y'all remember? You gonna like shut up, it was after the test, don't talk to me.
Is that when the body produces extra red blood cells?
No, it's telling you that your body needs to make, it's making new ones because you lost them. But the thing about it is, in one disorder, it's totally abnormal because they have totally abnormal hemoglobin in the first place. I shouldn't say total, but when they get sick or decreased oxygen states, then they have this problem that happens with hemoglobin S, sickle cell patient. So when you see their retic count high, it's very bad for them. But if I had an older person who had an acute blood loss, maybe I saw them, they had a GI bleed, and I see a retic count high, that is the normal response of your body saying you need to produce more RBCs. So for them, I want that. If you don't see that happening, then it's something going on in bone marrow, because it should happen after a person has an acute blood loss. But most of the anemias that we see, especially in this acquired type, have to do with chronic disease. So who are going to be those people at risk? I'm the oldest person in the room. So yeah, so it's going to be the person that's older or anybody who has chronic disease. And which two organ systems are the big ones?
Kidney
Kidneys
and the heart.
and the heart. Because those are the things you're gonna see if the heart's not pumping efficiently. So that heart failure patient that you just had in that last one, if you look at most of their stuff, when you look at lab values, if the kidneys aren't being fed, they don't produce what? What's that hormone you need to stimulate bone marrow? Erythropoietin. So if the kidneys aren't being fed, you have low erythropoietin, therefore your hemoglobin is low. So it's kind of a continuing cycle when you talk about patients who have chronic disease. And if you look at your kidney patients, that's pretty much the way they live. That's why they get Epigen as part of their treatment, is because what you want to do is stimulate their bone marrow to produce RBCs. So acquired anemia just tells you that it comes from some other source. The majority of people, especially when they're older, has to do with heart disease or kidney disease. So when they're younger, of course, it could be because they're diabetic. You know, older people do it just because they're just older. Anything that we do is after you turn 30, everything in your body starts going in the opposite direction. I'm not saying you don't stay cute. I'm just saying that the functioning of your body decreases over time. And so you're going to see those organ systems actually start to decrease function over time. So that's why you get more sensitive to medications when you get older, why they sometimes have to change your dosing based on those types of things. So that's what you want to kind of look at for your patient. So acquired anemias really have to do with decreasing perfusion to the kidneys for a lot of patients. So when they don't do that, they don't produce erythropoietin, and therefore they don't stimulate bone marrow to actually produce RBCs. Now, of course, when you think about it, you got to think about what that person looks like, because RBCs do certain things. They're going to carry oxygen. So more than likely, what's happening with the patient? When you're talking about clinical manifestation, what are you going to see when you do their assessment? How do they look? Pale. Because remember, RBCs have that color thing going on too. When you see real pale folk, check their H&H. Okay, because some of them look like the pillow sometimes. You're like, what? You go in the room, the patient is so pale till you can hardly see them against the pillow. That's how bad it can be. So, and that's rare, but every now and then you get a person who comes in with a hemoglobin of 4, and you're wondering how they're still alive. Because remember, that hemoglobin being that low means I'm not perfusing organs still. You know, you feel tired all the time, but you just kind of deal with it. It's kind of like life right now, right? You go to school, do the stuff you have to do. When you're tired, you just keep moving. A lot of people do that. They accommodate to the low hemoglobin levels. That's not a good thing. It's not good for your body to do that. Okay? That decrease in vascular volume is not good because that means the organs aren't being fed in the patient. So they're pale in color. They may be tired all the time, maybe winded just with doing a little bit of activity. They get up and walk to the bathroom and they feel tired. You got to sit on the toilet for 30 minutes because they can't get up. You know, it's little stuff sometimes you can pick up when you're doing your assessment on your patient to figure out what's actually happening with them. The other thing about patients who have low H&H, they tend to have a higher resting pulse rate. So even without activity, their pulse rate is high, and mainly because there's no volume circulating. Your body's trying to compensate for it by increasing your heart rate. So those may be things you see on physical assessment on your patient. One of the things to remember is even though the patient might have a low H&H, we don't transfuse immediately because blood is not without cost. You know, we kind of talked about that a little bit last week. But even when you give a person a blood product, they'll feel better within a day. You're going to look better because they'll pink up for you. They'll be able to tolerate activity better, all that kind of thing. But blood also runs the risk of putting people in heart failure. It runs the risk of patients having reactions. And sometimes it's not the blood product itself. Sometimes it's the things we preserve the blood product with, the citrates, that kind of stuff that's in there. But until you have a transfusion, you don't know, kind of thing. Okay, so we also have to worry about some of those things that can happen to your patient later. Generally, we do not transfuse patients unless their hemoglobin is below 8. Okay, so there are always doctors that have arbitrary kind of things. One of your things in life, if you ever see a doctor that writes an order for transfusion of patient and their hemoglobin is at least 10, because 10 is still on the low side, the patients can tolerate that. Patients can tolerate 9. But when you see doctors who write that you transfuse a patient at 10, always question the order. Because you run the risk of putting somebody into pulmonary edema just to give them a blood product when we can do some treatments for them to get them back to where they need to be. That's always like an NCLEX type question. That's always something like a test kind of question, because you wouldn't transfuse somebody at 10. Yes, it's low when you look at the hemoglobin curve, but that's still a person able to function and do things, okay? So if we're gonna give, you always look for the cause of an acquired anemia. So if it's brand new, you look for why it's happening in the patient. And one of the things that doctors do is actually, of course, they're going, yes, we're gonna do a CBC on the patient, but they also send it to pathology for them to look at the slide to see if there's something abnormal happening with the RBCs. If you see something happening in everything, you know, even though we're just talking about RBCs now, but if you have a patient who has lab work where the RBC is low, the platelets are low, and the WBCs are low, that means that person has something happening with bone marrow. That's more serious. Okay. Most of the time, you see patients who have hematology disorders on the one cell type. One cell type usually means it's something transient. That's how you have to kind of think about it. If it's all the cell types, then it's bigger issues. That's usually an oncologist or hematologist coming to see the patient so we can figure out what they have. So not only do you do a CBC at that point, you start doing bone marrow. Okay, so if they do bone marrow aspiration, they're just doing fluid. If they do a bone marrow biopsy, they're doing the tissue, so they're doing bone itself. So if you ever had a patient who went for a bone marrow, you know it's not the most pleasant thing. Sometimes they do it at the bedside. A lot of times they take patients down for a procedure because they used to do it and patients are wide awake, but now you see some people actually put a patient under and do it. But they take what looks like a corkscrew, like you take out a, you know, open your bottle of wine. They're going to put a person on their side. Make sure you check their PT and PTT before you do it, because if their PTT and PT are off, and you do this, patient can start bleeding all over the place. If they're thrombocytopenic, they can bleed all over the place after this is done. So you position them on the side. They're going to go on their iliac crest. Doctor gives them a little numbing, so they get some xylocaine there. And then they take that corkscrew and go around, push it into the bone, the ischial spine, and then they're going to just go around. Okay, so they're actually taking out tissue there. So if you watch it yourself, you're about to lose your mind. You know what you got to do though? Faint where? Backwards. All right, because they're going to clean off and do all that stuff, but you don't want to be fainting into the field that you're going into. But it's very sharp. They go into the bones of the hip, the pelvis, and then they take it out. So then when it's done, you got to hold pressure there. Make sure you get hemostasis because you want to make sure the patient isn't bleeding. A lot of times if the patient does have problems with platelets, that kind of stuff, you got to hold for a protracted period of time. But then if you turn them on their side, we usually put a sandbag under them because you want extra pressure there to make sure that the patient doesn't bleed. So post-procedure, make sure you're looking for bleeding there. If it's hard, that's a hematoma. So you got to continue to monitor the patients because you got to look at if they have a lot of stuff going on, they could have a lot of bleeding with it. But from that, doctors will look at the slides and see what the patient is. And then we go about treating it. If it's something that we can treat with medication, then you do that. So it may be the building blocks they need for iron, that kind of thing. A lot of times now you'll see patients get Epigen, especially for renal patients, they usually get it off dialysis or once a week, that kind of thing. If it's a patient that does need a blood product, then we go into that whole thing about making sure a patient signs a consent. The type and cross, when you're transfusing blood for a patient, only goes with normal saline. Has to have 2 nurses at the bedside. And then when you're giving the blood product, always start it slowly. Probably want to go about 50 mLs per hour for that first 15 minutes. Make sure your patient is tolerating it. Like I said, I never tell them everything that can go wrong because they have everything you tell them. Okay? But you're looking for febrile reactions. You're looking if the patient has anaphylaxis. And then the other one that you're looking for is hemolytic reaction. In your textbook, they have a lot more reactions, but those are only 3 you got to think about. Febrile, anaphylaxis, and hemolytic. Okay. Patient has either of those, blood stops. Okay. You want to make sure you check a set of vital signs. Blood stops and you get rid of, make sure you have an open IV line, but blood shouldn't be in that tubing anymore. Take it down, just have the saline, flush it, and then you may have to give medications based on what's happening with the patient. With febrile reactions, you want to make sure you check the vital signs, call the doctor, find out what they want to do. There will be some patients who have a febrile reaction. Doctor still says give the blood. because the patient needs it. So they're going to tell you, give the patient Tylenol, wait 45 minutes, and then restart the blood product. Now remember, that time ticking off is still ticking in that 4 hours that blood can hang, because that's the maximum 1 unit of blood can hang is 4 hours. Okay. If they have an anaphylactic reaction, a lot more, fancy kind of thing, because this is the person that's going to be telling you, I can't breathe, you may see hives, welts, all this kind of stuff going on. Sometimes it's the blood product, sometimes it's the citrates that are preserving the blood product. So that patient also is going to stop the blood product. Make sure you have an IV site that you can use, because you're likely going to have to give patient medication. So think in your head is that immune response, you can know what medication I'm going to have to give the patient. So we know steroids are going to be there, because you got to get rid of that immune response. Benadryl, because that's what you deal with when patients are having anaphylaxis, allergic reaction, you're going to give Benadryl. And then depending on how much their airway is impeded, you may be giving Epi. Think about the kid having reaction to peanuts or something. It's the same kind of process you're thinking about when you talk about a blood product. So you may have to give epinephrine, Benadryl, and Solu-Medrol to the patient. All right. If you have a patient who has a hemolytic reaction, this is a person that's usually just sitting there shooting the breeze with you, and all of a sudden starts to tell you, my back really hurts. And it starts to hurt even worse. And then their urine can turn red. If you have a Foley catheter, it's great. It's great to see, but it's not great for the patient. But you'll see a person go from clear yellow urine to like tea color to bright red. That's how as fast it can happen in a patient. So what is happening in that one is the antigen antibody reaction that is attacking the basement membrane of the kidneys. That's what's going wrong with the patient. Okay, so hemolytic reaction usually results in the patient telling you they have back pain. That's why you don't tell them everything that can happen, because you know if you told somebody, when I'm starting this blood, that you might have some back pain, what's going to happen? Well, my back was hurting, but I don't know if it's really that or this. So then you don't know either. So just, I always just tell them, I say, I'm going to stay here with you for the first 15 minutes. Let me know if you feel anything different, because then you're not giving them any idea about what they should be reporting to you, and they'll let you know what's happening with them. Now, hemolytic reactions are a little different. Yeah, you turn off the fluid, make sure you have a good, and the blood product, make sure you have a good IV source. Not really sure right now whether we have to give meds, because you may have to give some medication to the patient. But what also happens with this one is you need to actually draw a blood specimen, and a urine specimen need to go down to the lab for the patient. Now, all these patients who have reactions, no matter what it is, if the doctor told you to stop it because the patient was having a febrile reaction and not give the patient any blood product anymore, if you have a patient who had anaphylaxis, patient who has hemolytic reaction, the blood product itself goes back to the blood bank. Because the blood bank now has to figure out, was it something you did at the bedside, or was it something they did in the blood bank? So that all has to happen when you have blood reactions. Make sure you document what happened with the patient, how they responded to any interventions that you did with them. And doctor always has to be called. Okay. Sometimes they have a protocol that accompanies the blood. You just activate it when the patient is receiving the transfusion, but always, always make sure you document what happened with the patient. And I think I told you last week, only normal saline can run with a blood product. Okay. And then they can give factors based on what's happening with the patient, but we're mostly considering RBCs for us. So then we have thrombocytopenia, which is just low platelets. That's the long name, the actual name for when a patient has low platelet levels. So platelets are generally, you look at lab values of 150 to 400. When you talk about what's normal for platelets for people. Platelets are ones that, when you see disorders that happen with them, tend to be ones truly that are self-limiting. Because RBCs take about 120 days to refurbish. So it takes a while for them to come back. Platelets only live for 5 to 7 days. So if you get rid of the problem, then the patient resolves it easier, because it doesn't take that long to make new platelets. So that's the good thing. But when you have patients who have thrombocytopenia, you're talking about a patient who has low platelet level. So that means they're going to be at risk for bleeding. Their whole mindset is, and I told you there's two basic different types that we look at when we talk about these. There's the idiopathic type, which is the majority of people. We don't know why it happens. Okay. Then we have some patients who have autoimmune thrombocytopenia. Okay, these are people that actually have thrombocytopenia because the platelets are allergic to each other per se. There's some type of allergic process in your body that's killing off your platelets. Okay. That one is the more serious of them. Not that bleeding isn't serious on both sides, but I have to get that autoimmune or that inflammatory response under control. Because it's autoimmune disorder, we have to get rid of it. Otherwise, it just continues to kill off the platelets. It just continues the process. So if you have a patient who has that, guess what they get? We already know what we always give them, right? We're going to give them steroids. So that's the initial thing you do, and hopefully you get that whole process under control. If it does not, and the patient continues to have this process that's happening all the time, platelets are staying low no matter what we do, okay, the next thing they're going to do is try to actually take the person's spleen out. Okay, because a lot of times that's the cause of why it's happening with the patient. Now, of course, that's not going to be a good surgery to do, right? Because what's already happened? Their platelets are low. You got to worry about even more bleeding because their platelets are low in the first place. So dangerous surgery. The good thing is, like a lot of times, most of the patients will respond to steroids being given to them. But does it happen for everybody? No. That's that you try to save surgery as a last resort, mainly because you got to worry about not only the regular risk of bleeding that we have, but the extra because this platelet issue is going on with the patient. Now, the reason you don't give a lot of platelets when it's autoimmune in nature is because if you give it to them, it just kills them off still. You can give it to the patient who has other types of thrombocytopenia, but as long as it's autoimmune in nature, you don't want to keep giving platelets because all it does is just continue the process. You got to get that under control first before you can do transfuse platelets on a patient. Platelets, if you ever have to transfuse them in the patient, same thing, it's a blood product, so it still always runs with normal saline. But the difference about platelets, remember how blood, I said you have to run it over a couple hours if they're young and healthy. As they get older and more stuff wrong with them, you let the blood run longer. Platelets can run in pretty fast. Platelets, fresh frozen plasma, those types of things, you don't have that time constraint as far as I can't give them, I can give them fairly quickly for those patients. Almost like you're giving an antibiotic. I can run them in over an hour, 30 minutes to an hour for the patient. And a lot of it will depend on what's happening or what's going on with the patient. Okay, some patients just get the platelets themselves. If you got something with some real bad kind of crazy stuff going on, they usually get fresh frozen plasma as well. Because you try to replace all of that so the patient doesn't end up having a problem. Assessment-wise, you want to make sure you're looking, and the thing about patients who have thrombocytopenia, you can have people that go all the way from you don't see anything, all the way to people that have bruising all over their body. Because they do it all. They'll end up, some patients who have little petechiae kind of scattered, all the way up to, if you took their gown up, you would almost gasp at how big the bruises are all over their body. So just know they can do all varying types of things that happen. Generally, when your platelet level goes below 60, that's when a person can have spontaneous bleeding. So sometimes you'll see a patient just sitting there talking to you, blood will trickle out of their nose. So those are the kind of things you're looking for. If you start to see changes in mentation on a patient who has severe thrombocytopenia especially, you worry about whether or not they have a bleed in their head. Yeah. But little things as far as injury goes for them can cause big time ecchymosis, bleeding into a joint, all that kind of stuff. So just think about, I'm looking at them, you know, make sure you pull things back so you actually look under clothing, because it can be catastrophic. Just, they look fine up here, but if you took the gown up, they look totally different. So make sure you're doing that type of assessment on this patient. But they can go anywhere from, like I said, petechiae all the way to confluent, what we call, the ecchymosis is so great you can't even see regular skin anymore. Everything is so bruised up on this patient. And that can affect their H&H. You know, because platelets are low, but I can also, because they're bleeding under the skin into a joint, you know, they walk by something and hit it. For us, it would be just, ow.